It was a very nice case about the mitral valve and also the atrial appendage closure, and it was done with an amulet device. I want to show you a little bit of an experience that we have. We use Watchman. That's the Boston Scientific's version of the left atrial appendage closure. AFib, just as a background, we all know this, just kind of remind that there are a few perspectives that are very unique to India. The all-cause mortality is pretty high for 100 years of patient years compared to other Western countries. And a lot of factors here. And AF, for example, is not very well treated in this country in many ways. We tend to rely on aspirin to prevent strokes. We tend to use the novel anticoagulants, the new ones, less often than otherwise. All these put together makes AFib quite dangerous for a stroke in India. The economic burden is very high, and the mean direct health cost is about 5 lakhs. That's a lot of money per year. This is 2014 rupees and not in 2023. And the appendage closure is probably a very nice option to prevent the stroke in AFib in India. I think it's very well suited. I know the procedure here is not done as often as it is being done in the rest of the world, but I think it's pretty unique and quite applicable for our situation here in India. The appendage closure is picking up very rapidly. It's actually very happening more commonly in Western countries, and I practice in US, and we do about 250 to 300 appendage closures a year. Our device of choice is, as I said, it's the Watchman device from Boston Scientific. And we have done more than 800 of these in the last 4 years. And I want to point out the things that we have learned in the process. We managed to reduce the procedure time to an average about 12 to 15 minutes skin to skin. It's become quite slick to do it, and it's also quite safe in many ways. And many of these patients are about 85, and they tolerate the procedure really well. So this procedure is quite applicable. And the key components of the procedure, as you can imagine, is the vascular venous access, the transeptal puncture. They form typically the bleeding complications that tend to happen. The appendage closure itself, it's a self-expanding device and occludes the appendage completely. And the idea here is to avoid any leak around the device and also to reduce the formation of thrombus on the device. That is the device-related thrombus. Successful closure of the appendage vascular access, as you can imagine, is a large bore access. It's a 16 French sheath. Complications like hematoma, retroperitoneal bleeds, and pseudoaneurysm and AV fistula are the most common ones. And the transeptal puncture, typically the pericardial effusion and the tamponade. And right-sided perforations tend to happen more often than the left. That's what we have noticed more often. And the device size selection, most of the times when we started the program, we went by the IFU suggested by the manufacturer. We tend to use smaller devices, as they would suggest, that had more perivalvular leak and more instant of device-related thrombosis. As we started using the larger devices for the size of the appendage, we realized the leak at 45 days is almost none, and our device thrombosis rate is almost 0%. Closure of the access device, we use double percutaneous closure system with perclose. And figure of 8 is a very good option. We just saw a very nice demonstration of figure of 8. And I would say if that's what you feel comfortable, that's a fantastic thing to do. Just to give a little bit of a pictorial view of it, the double perclose system, the first perclose goes in, and the second perclose goes in. After the second, we usually use the Amplatz wire to form the stiff rail. As the second one comes out, this allows for the 16 French sheath to go in easily without causing any hematomas at the groin area, and also allows for the sutures to close well. That 16 French sheath, because the Watchman device that we tend to use is 15 French, It's nice to do it through a sheath system rather than using their system without a sheath. A bare insertion of their delivery system will not give us enough control. That's why we tend to use a 16 French sheath with it. And that also we found a nice, both safety-wise and time consumption-wise. It's been very helpful for us. And the other thing that we found out is during the transeptal system, most of the times we tend to verify it in two views, in the long axis view and the short axis at the base. And it is always suggested to have the needle both inferior and posterior. And in our experience, what we found out is majority of the times, mid works really well. If you go too posterior or if you go too anterior or inferior, that's when the pericardial effusion rate goes up. And my suggestion is, with our experience, stay mid to mid. The success rate for the device deployment is very high. And having transrectal needle on a pressure flush also helped us quite a bit. And once you cross, you know that you have crossed the septum with the bubbles, and then you can we use the Torre wire. Torre wire is a coil that goes through the needle and stabilizes inside the left atrium, so you can get the system out and put your delivery sheath in without difficulty. That's also very beneficial to use. Instead of using an Amplatz wire, trying to find a pulmonary vein for safe location, they are actually both time-consuming and it does cause issues. It's better to put a Torre wire that it's a coil that stabilizes in the left atrium, and then you can do your sheath exchanges on that one. And the other trick we really found out is, with the vascular anatomy is tortuous in the groin. Sometimes the needle will not reach the transeptal. Even if we do the SL sheath or the Mullen sheath or BRK needle, bent quite a bit, it still doesn't work well. And we found out using a long sheath, a 65 centimeter 16 French sheath, straightens the vascular access system and makes the septal reach easy. And that has saved us literally sometimes 40 minutes of time. And when doing the appendage closure and picking the device itself, and try to pick the ostial size in two views for sure, and take a kind of a mean of that, an average size would help you quite a bit. And these are the sizes that I'm talking about, Watchman. I have more experience with Watchman than with Amulet, and my general preference is Watchman. It has some advantages compared to Amulet device. Goal is to fill the appendage. The difference between the Amulet and the Watchman tends to fill the entire appendage with a nitinol acorn-shaped device. And we tend to err on the larger side of the appendage if the appendage has enough depth on the volume, and we tend to achieve a compression of 20% or higher. That makes a big difference for us. And that has reduced our both valvular leak and also reduced our thrombosis risk. And angiogram of the appendage sometimes helps to identify lobes that are not seen on the TEE. And you saw the appendage, and when we are deploying the device itself, if you are in the RA caudal view for the fluoroscopy, if you point the device right up towards the roof, you come out right, almost always. And it tends to close all the wings and whatever broccoli shape or chicken wings, whatever it is, we tend to have better luck with it. And we tend to do, if we use contrast, we tend to use in two views. Two orthogonal views work really well for us because we have identified leaks on the fluoroscopy and contrast that the TE did not pick up. And doing two orthogonal views with contrast helped reduce avoid the perivalvular leak at 45-day TEE that we tend to do for these people. And one other thing that we have in our lab is this, accept a shoulder over a perforation. And what I mean by that is, in this 135-degree view, you will see the shoulder on this side. And if you try to make it as coaxial, as flat to the appendage ostium, if you do too many attempts of capture and recapture and try to deploy the device, the perforation risk goes up. And my general suggestion is, if you got a good compression, if you have a good depth of at least 2/3 of the device into the appendage, accept a good compression and come off with a slight shoulder rather than taking a perforation. And a word about anticoagulation strategy. I'm almost up at my time. We use dual antiplatelet therapy with aspirin and P2 vital inhibitors, either clopidogrel or ticagrelor. Most of these people already have stents, and they are already on DAPT, so we tend to leave that, and this worked really well for us. And we've been doing it for about almost 2.5 years, primarily using this as an anticoagulation strategy. And we don't have any incidents of DTR at all in the about close to 600 cases we have done. And anticoagulation, if you use with vitamin K antagonists like warfarin or NOACs for 45 days followed by aspirin, we don't do 6 months of DAPT after the 45 days once you stop. And that also worked very well for us. So my takeaway points for this is use a sheath system to deliver the device and keep the anticoagulation very simple. After the device deployment, DAPT works really well. And there is enough data to show that, but we have been doing only DAPT for 45 days and still coming out well, both for thrombosis and for any other complications that we may have. And I really urge to look into the left appendage closure programs. It's a big service to the community, and it's a big service to everybody. Thank you so much.